So next we're going to have our Q&A session. I'm sure everyone have learned a lot over the last 2 days. So please, if you have any clarification, you can ask Dr. Epstein. I'll just please remind you again to raise your hand and introduce yourself before you ask your question. So we can start taking questions.
Let me also just say that even if I have not covered any issue that you may have a question in urological pathology, since this will be the last Q&A, feel free to ask any question that you have, and I'll do my best to try to answer.
Yes, please, Dr. Raj.
I'm Dr. Rajan from Farvania Hospital. One or two questions. Do you believe in this U-pump category they put in the new classification, which is synonymous with urothelial hyperplasia?
Yeah, so as I mentioned, the entire entity of papillary urothelial hyperplasia has undergone kind of controversial terminology. So the last WHO, not the current one, they came up with this U-pump, urothelial proliferation of uncertain malignant potential. And to me, I never liked it because it wasn't descriptive. It didn't convey anything about the morphology, that it looks like this little tenting, little kind of papillary-like structures. And U-pump never caught on, at least in the United States. I mean, of all the consults I ever got, I think maybe one or two used the term U-pump, but for the most part, it was never used, despite the WHO. So, WHO is not the Bible, not the Quran. It's, written by some people, and sometimes most of the time it's good material, but, sometimes, not necessarily. So the latest WHO, basically they didn't even deal with the entity of papillary urothelial hyperplasia. In the beginning of the chapter on papillary urothelial neoplasms, they talk about basically how there was this entity, papillary hyperplasia, the old edition called it U-pump, and basically we're not going to deal with it in this WHO. They just pretend like it doesn't exist. It does exist. You do see it. So I think the WHO should have given it a name, or at least try to deal with it. But I still use the term papillary urothelial hyperplasia. To me, it describes that it does have this little papillary look to it, but it's more hyperplastic than a true neoplasm. The criticism for the term papillary urothelial hyperplasia is some experts felt that the term papillary should always mean discrete papillary frond, not just this little tenting.
Okay. And do you use isochrome 12 except in that case scenario you told when it's a post-pubertal testes with a prepubertal teratoma? Any other place?
Yeah, so the use of isochrome 12P is, so it's not a routine test, number one. Literally, I think probably maybe only two or three, a handful of centers in the entire United States look for isochrome 12P. We developed the technique for looking for isochrome 12P. So we do it. And the scenario that I will use it, and I'll mention that kind of in the slide seminar as well when we go over some of these examples, is prepubertal type teratomas, which are benign, that occur in postpubertal males, 18, 20, etc., are very rare. And it's a tricky diagnosis, as I'll show you. So for me, I'd like to feel 100% comfortable in that scenario before I tell that patient it's benign. And consequently, in that scenario, I will do isochrome 12P to show that there's no amplification. But it's not, I would say, probably not 100% necessary to do it, but it's just, for me, reassuring. The other thing to be aware of is not all malignant germ cell tumors have isochrome 12P amplification. About 85-90% do. So it still could be a postpubertal, i.e. malignant teratoma, even if you don't see the amplification. So it's not foolproof.
Thank you. Thank you so much.
Yeah. Any other questions? Yes, please, Dr. Naki.
Yeah. If in case we get a situation in which we are seeing one or two small nests of cells in the lamina propria, but there's no stromal retraction around them and there's no paradoxical differentiation, can we still call it lamina propria invasion?
Yeah, so sometimes you may be able to call it. If the nests, so your differential is going to be basically some of the entities I've talked about. So one would be proliferation of von Brun's nests. But if you see just a few small irregular nests, very small, that's not von Brun's nest, so you've ruled that out. You might then think, could it be pseudocarcinomatous urothelial hyperplasia? You rule that out because it doesn't have the hemorrhage, the hemosiderin. So sometimes even just a few of these nests, the other thing you have to consider is also just tangential section. So in a case like that, I would probably do levels to make sure that it still stays the same. It doesn't end up looking more like it could be a tangential section. But ultimately, even in the absence of retraction artifact, absence of paradoxical differentiation, if you have small nests down where they shouldn't be, you still can call lamina propria invasion in some cases.
Thank you very much.
Yes, please, at the back.
Please, I have a question about the papillary region in the context of follow-up cystoscopy for a non-case of a non-invasive papillary region, and you have got a papilla that you are not sure it is a true papilla or undulating surface. And actually, should you lower your threshold and diagnose earlier recurrent non-invasive papillary carcinoma, or you just give it as papillary urothelial hyperplasia?
Yeah, so in that case, there are cases that happens fairly routinely with me, where I see small, especially on a small biopsy, one or two papillary structures. So first of all, I would say you should always be cautious calling a papillary urothelial tumor, either pun lump, low-grade cancer, on a one or two fronds. Because typically a papillary tumor, when you think of it in the gross, is not two little structures poking out. It looks like a cauliflower or a tree trunk poking into the bladder. So when you see only one or two little fronds that you're thinking, could this be a low-grade papillary cancer or a pun lump, for example, what I would do is check with cystoscopy. If they describe, and sometimes it is a big tumor and they're just doing a small biopsy, and if they describe that there's an obvious papillary tumor, then I'll feel comfortable calling it a papillary, for example, low-grade non-invasive papillary cancer on the specimen. But if, on the other hand, they describe it was erythema or there was no definite tumor, then I would not be definitive in calling it tumor carcinoma.
Yes, Karen, please.
Dr. Epstein, this is something that we discussed yesterday, and it pertains to prostate core biopsies and the assessment of the tumor percentage within the core. And I wanted to make sure I understood this correctly. So when you described yesterday that in a core, if you have discontinuous tumor involvement, as in you have two separate foci and you have a bit of benign prostate tissue in between, how do we assess the tumor percentage in that core? Do we take both the tumor bits separately and then clump it up together? Or I think you said that the tumor may be involving the core irregularly, and as a result of that, you assess the entire length as tumor percentage.
Yeah, so just to clarify, 85% of the time, and these are studies based on morphological studies correlating with radical prostatectomies, even molecular studies, 85% of the time when you see a little bit of cancer on one part of the core, a lot of benign tissue, a little bit of cancer, that means it's the same cancer going in and out of the plane of section. So what you're trying to convey to the clinician is what's the minimum length of that cancer that we know is in that patient. So if I see a little bit of cancer here, a lot of benign tissue, another little bit of cancer, I know the minimum length of that cancer in that patient is going from one end of that cancer to that other cancer. So in that case, I would say there are small foci of 336 discontinuously involving 80% of the length of the cancer, as opposed to mentally clumping it together and saying it's 5% of the cancer, of the core.
Because that would change a whole lot of our reports.
Yeah, absolutely. But I think it's important because you want your histology. We don't do, in our institution, we don't do histological descriptions. We just give diagnoses. If it's a complicated case, I might describe the histology. But nonetheless, you want your histological diagnosis to match what's on the slide. You don't want to disconnect. So in a case when you do have a little bit of cancer, a lot of benign tissue, a little bit of cancer, you don't want to just say prostate cancer involving 80% of the core, because somebody else picks up that slide and they're going to say, this doesn't make sense. But if you say small foci discontinuously involving 80% of the length of the core, then there's a match between your histological diagnosis and what you're seeing under the slide.
Thank you.
Yes, please.
Yes, I want to ask about the elevated level of beta HCG in cases of the seminoma. Sometimes after level is high, the serum level. So these cases, are they managed as non-seminoid stem cell tumor?
Yeah, so I would say two things. One, I would look at how high the level is. If the level is in hundreds, even low 1,000s, I would look at the tumor and see if I see a lot of scattered syncytial trophoblastic giant cells. If I see scattered syncytial trophoblastic giant cells and the serum HCG is the hundreds, maybe low 1,000s, you don't have to keep looking for choriocarcinoma. But if the level is in the tens of thousands, or if you do not see scattered syncytial trophoblasts to explain the minimally elevated serum HCG, then yes, you do have to keep looking to see could there be a choriocarcinoma component. Now, the other possibility, and this can exist, is you can have a pure seminoma. This is uncommon or rare, but it happens. Even a pure seminoma can metastasize as a non-seminomatous germ cell tumor. It used to be thought that seminomas were kind of one end of differentiation, non-seminoma another end of differentiation. So if you went to seminoma, that's it. They couldn't go any further. But it's been shown that even pure seminomas can metastasize, for example, as a choriocarcinoma. So if you extensively sample the specimen, didn't find any syncytial trophoblasts, didn't find choriocarcinoma, and the HCG was elevated, the possibility the patient could have metastatic choriocarcinoma is still in that setting. But the key thing is when you're looking at the gross for a testicular tumor, look for any areas of hemorrhage, because that's, again, where you would more likely find choriocarcinoma.
Yes.
Book, by the way.
Oh, thank you.
And building up on just that, especially the bladder is something that we refer to this like every day, because I have some little questions regarding the part just Dr. Naki discussed with you, the non-invasive versus invasive bladder tumors in the biopsy. One thing, is there any role of looking at the basement membrane or any collagen stains when we have very rare isolated nests we're not really sure about, that if they are invasive or not without the retraction artifact and paroxysmal stuff? And then second, if we have a very superficial biopsy in which we are not confident that there is stroma or not, or there is abundant stroma or not, or we are suspecting just tangential cartostroma, do you guys recommend a rebiopsy, or you would say that this is at least superficial and then we recommend a rebiopsy, or just call it non-invasive straight away?
Sure, that's good, both good questions. So it turns out, unfortunately, that, for example, both in the uterine cervix and in the bladder, that invasive tumors can make their own basement membrane or type 4 collagen when they invade. So any of those types of collagen stains end up just not being useful in terms of invasive versus non-invasive. And in terms of a superficial biopsy, there are cases where you get a very superficial biopsy, and in those cases, the scenario can be several situations when you get a superficial biopsy. There are some cases when you get a superficial biopsy and it shows high-grade cancer, definitely urothelial cancer, but it's superficial. But you don't see any stroma. In that scenario, what you want to say is superficial fragments of high-grade urothelial cancer. Say the biopsy is superficial, we don't see lamina propria, invasion cannot be determined on this superficial biopsy. Sometimes we get a superficial specimen where we have only kind of benign urothelium and nothing else. Again, what you should say is superficial fragments of benign urothelium, no lamina propria is identified.
Please, Dr. Mara.
My name is Dr. Mara Al-Wazan, Amiri Hospital. My question regarding teratoma. We know that if it is like somatic malignancy, we see it in less than 5%. We disregard it and ignore it. But my question is, if there is multiple sites of these somatic malignancy or in multiple blocks, do we still lump them or what do we do?
Sure. Yeah, so if something looks, for example, like immature neuroepithelial component or skeletal muscle component, in order to call a somatic malignancy, you need a pure, somewhere on the slide, a pure 4x or 5 millimeter, they're basically equivalent, sheeting out of that element without any intervening teratoma. So if I see, for example, something that looks like rhabdomyosarcoma, some rhabdomyosarcoma, some teratoma glands, some rhabdomyosarcoma, some teratoma glands, that's not going to be somatic malignancy. It should be, this is a tumor that's wiping out things and just growing. So basically what I end up doing is I take my 4X lens and I look and under the microscope, and if it's pure rhabdomyosarcoma, nothing else in that 4X lens, that's a somatic malignancy. Same thing with the immature neuroepithelial. You don't go adding things up for all the different slides. It's just in any given slide, do you have an area where you have pure, it has to be pure, without intervening teratomatous elements, pure somatic type tissue group that's basically 4X lens or more, or 5 millimeters or more, same thing.
So it doesn't matter that we have multifoci of less than...
Nope. Sometimes you will see postpubertal teratoma with a bunch of multiple foci of immature neural epithelial or multiple foci that look like rhabdomyosarcoma. None of them measuring over 4X, and then you don't. Now, the only exception, and let me clarify that, sometimes you put through, you don't typically put through the entire testes. You sample typically testes. So one thing about sampling, especially for residents if they're here, is we often have a rule of 1 centimeter per tumor. That rule of 1 centimeter per tumor applies to big tumors. So when you get a 20 centimeter sarcoma, what do? You don't put through 100 sections. You might do 20 sections. But when you have a small tumor, like a testis tumor, which is 3 or 4 centimeters, you don't put 3 sections. You want to put through extensively sample that testis. But typically, we still don't put through the entire testis. Now, if I'm looking at a slides of my sample testis, and I see a lot of immature neural tissue, none of them exactly fitting to a 4X field. Maybe it's half a 4X field. Then I see a few teratomatous glands, but there's a lot of it. What I will do is put through more of the testis through, because that sometimes is a clue that somewhere else there will be diagnostic areas that you can get to being a somatic malignancy.
Thank you.
Sorry, Dr. Nahib.
Yes, Dr. Epstein. Sometimes we encounter bladder biopsies showing invasive urothelial carcinoma invading in smooth muscle bundles. But the thickness of these smooth muscle bundles at times is not very thick, so we are not sure whether this is part of the deep muscle or whether it's part of the muscularis mucosae. So how do we resolve this issue?
Yeah, so in 2 things. One, sometimes, as I showed, I will do a Desmond, and if it shows a lot more muscle than you thought on the H&E, that sometimes can get you to calling it muscularis propria invasion. But sometimes you end up just using that note. We call it, we have a macro called QMUS, which basically says, we don't know. We can't tell if it's muscularis precosa or muscularis propria. And in those situations, you want to sensitize the urologist to go back and do an additional TUR to see if they can find definitive muscularis propria invasion.
Okay. Dr. Raj.
I know it's a long topic, but if you can shed some light on the spindle cell lesions, the post-operative spindle cell nodule versus I have a little bit of it.
Right. I think I have one in the slide seminar. I'm pretty sure I do. And so we'll go over that then.
And the role of glypican-3 in growth factor, do you...
Sure.
Well, it's difficult to pick up.
Yeah, so one of the situations, both AFP, alpha fetoprotein, and beta HCG can be elevated in the serum. And so when we use an antibody for either AFP or beta HCG, as I mentioned before, sometimes it gets very dirty. The slide is all brown, and it's hard to interpret. So for yolk sac tumor, I prefer glypican-3. It's just as sensitive as AFP, but it's a cleaner stain. As I'll mention, I have another marker that we use at Johns Hopkins for trophoblastic disease. That's also a cleaner stain for trophoblastic disease. But yeah, I would prefer glypican-3 over alpha fetoprotein. Yeah.
Yes, please. Yeah.
Sorry, doctor. Just one more question regarding invasive urothelial carcinoma on a biopsy. Do you guys have any recommendation that we need to stratify it, that's the sort of variant we're dealing with, or we just can leave it as just invasive urothelial carcinoma?
Sorry, could you repeat the question?
In case of biopsy, bladder biopsy, and you have invasive urothelial carcinoma, and do you have to typify it that which exact variant this is, like plasmacytoid?
Sure.
Or like,
Yeah, that's a good question. Yep.
Yeah.
So there are different subtypes of urothelial cancer. I'll cover a couple of them at least one of them with the slide seminar. And you should mention them. For example, plasmacytoid, especially some of the ones that are more associated with a more aggressive behavior. So the plasmacytoid variant of urothelial cancer is a more aggressive subtype. It also has an unusual predilection for when they recur. They recur with carcinomatosis in the abdomen, which is very different than regular urothelial cancer. So that's important to know as well. There are some urologists, if you diagnose plasmacytoid urothelial cancer invading the lamina propria, some of them will actually do a cystectomy even. Similarly with micropapillary urothelial cancer, you have to be very careful to separate out micropapillary urothelial cancer versus just retraction artifact. So you have to be very cautious. When I call micropapillary urothelial cancer, it's multiple nests that are similar size and shape in a big space, whereas retraction artifact is a single nest of tumor with its own space. So when you call micropapillary urothelial cancer, if you do call it, again, you may get a cystectomy, even if it's invading the lamina propria. So you have to be very careful calling micropapillary invasive cancer. I was part of an inter-observer reproducibility study on micropapillary invasive urothelial cancer, and there was a lot of differences amongst pathologists what they would call micropapillary urothelial cancer. So cautious in that standpoint. And then there are some cancers, like I'll talk about lymphoepithelioma-like variant, which is associated with a better prognosis. So you want to note that as well. The more common subtypes of what's called divergent differentiation in urothelial cancer is squamous differentiation and glandular differentiation. It's important to just mention urothelial cancer with squamous differentiation or urothelial cancer with glandular differentiation. They're treated the same, prognosis is the same. The importance of mentioning it is, for example, in a metastatic site, it may metastasize as pure squamous cancer or pure adenocarcinoma. So knowing that the bladder specimen showed features of urothelial with glandular or urothelial with squamous could help if somebody finds a metastasis, knowing that it came from the bladder. Some places in the United States are recommending that you give percent of those subtypes or variants, like percent squamous carcinoma, percent adenocarcinoma. I would say that's more from a research standpoint. At this point, not so much clinical. Because again, for squamous and adenocarcinoma, which are the most common subtypes, they're treated the same. The other type of divergent differentiation, you can see a small cell carcinoma associated with urothelial cancer. Sometimes the clinician also, most of the time, the small cell cancer is the predominant component because it's just so rapidly growing. But some clinicians want to know, is it 90% small cell, 10% urothelial, or rare case of 10%, 90% urothelial, 10% small cell. So in those cases, you may want to give percentages.
Right, thank you so much. Just one, building up on we're talking about variants. Sometimes when you have neuroendocrine in the bladder, or sometimes poorly differentiated, like a very high-grade tumor, and that will tend to lose the neuroendocrine markers. So that, I think, becomes a very difficult case scenario in order to come up with how to typify the tumor.
Yeah, so the types of neuroendocrine differentiation you get in the bladder it's easier than prostate in one respect. So prostate we talked about yesterday, how just usual prostate cancer can have neuroendocrine differentiation. So you have to be careful if you see neuroendocrine differentiation immunohistochemically with prostate cancer. It may mean nothing, or it could be small cell cancer or large cell neuroendocrine. So that's very difficult sometimes. Bladder, it's easier because normal urothelial cancer never has expression of neuroendocrine markers. So if you see something in the bladder that has neuroendocrine staining, it could be a carcinoid tumor. I'm going to show an example of that in the slide seminar. It could be small cell carcinoma, which will look like small cell carcinoma any other site. Small cell carcinoma may be admixed with urothelial cancer, squamous cancer, adenocarcinoma. And the more tricky is sometimes you can see large cell neuroendocrine cancer. But those are going to be large nests, central necrosis, and they should be pretty diffuse neuroendocrine staining with a very high Ki-67.
Okay, thank you. And sorry, just one last question. Regarding the kidney tumors, we were discussing yesterday about the staging for the renal sinus fat tumors, like the tumors we see in the renal sinus fat. For your in your institute, do you guys imply some sort of criteria that to call renal sinus fat invasion, you need the tumor to be in direct contact with the fat in case of when we see a nodule maybe encased on 2 sides or 3 sides by fat, but still circumscribed, not touching the fat directly, the tumor cells. What is your take on that? And just does it has to be touching or not? That's the
right. So good question. The vast majority of times when you see, let's say, a renal cell cancer, and then in the fat you see kind of nodules, rounded nodules, the vast majority of those cases are invasion of segmental branches of the renal vein. And it can just fill up the entire vein, that it looks just like a rounded nodule of tumor. But if you look carefully, you'll see a thin muscle wall around those nodules, indicating invasion of segmental branches of the renal vein. Almost always that's the case.
Okay. All right. Thank you. Thank you so much.
I believe our time is up for this session. Thank you for your contribution, and thank you, Dr. Osteen. So now we're going to have the lunch break for 1 hour and reconvene after that. Thank you.